Good evening, sir.
Yeah.
So my topic is hydrocephalus. So hydrocephalus is an abnormal increase in the amount of CSF resulting from a disturbance of either formation, flow, or absorption of CSF, which is resulting in enlarged cerebral ventricles, usually increased ICP. Causes of hydrocephalus are increased CSF production like choroid plexus papilloma, or obstruction to pathways either in the lateral ventricle, third ventricle, aqueductal stenosis, or in the fourth ventricle, or decrease in the absorption of CSF because of obstruction at the level of arachnoid villi, dural venous sinuses, or extracranial venous sinuses by plugging of tumor cells or any part of blood clot, proteins, or bacteria. Classification: it is classified into acquired and congenital, and communicating hydrocephalus and non-communicating hydrocephalus. Where in communicating hydrocephalus, CSF can escape from the ventricular system into the arachnoid villi, but it is not able to absorb by the arachnoid villi. So it can be because of increased CSF production or obstruction at the level of arachnoid villi or extradural venous sinuses. The hallmark sign is dilatation of entire ventricular system in the radiological imaging, where in non-communicating hydrocephalus, which is otherwise known as obstructive hydrocephalus, and it is the most common cause of hydrocephalus. It is due to structural obstruction in the pathway of CSF. So here the sign will be a dilatation of the ventricle, which is proximal to the level of obstruction. Congenital hydrocephalus causes arachnoid cyst, colloid cyst, Arnold-Chiari malformation, and Dandy-Walker malformation. Clinical features. Clinical features varies according to time of onset, whether in the infancy or in the adulthood, and the rate of rise in ICP and associated structural abnormalities. In case of infants, the size of the head increases in the rate greater than the facial growth. So the head circumference will be more. There will be frontal bossing, bulging of anterior fontanellae, enlarged and engorgement of scalp veins, thin and shiny scalp skin, poor head control, delayed milestone, irritability, lethargy, and nausea, vomiting, or hyperactive reflexes. Signs which include McEwen sign, which is crackpot sound on percussion over the enlarged ventricle. Sunset sign, where upward gaze palsy, the gaze will be downward because of a stretching of a suprapineal recess or stretching of the midbrain. And the cranial nerve palsy, most commonly sixth nerve, which has the longest course intracranially. So there will be convergence squint. There can be stretching of vagus nerve leading to stridor, stretching of optic nerve leading to cortical blindness, and stretching and the compression of medulla midbrain lead to irregular respiration and apnea. In older children and adults, because of rigid cranial vault, the signs of raised ICP will be prominent. So they'll be having headache, nausea, vomiting, papilledema, and they can also have the upward gaze, abducent palsy, gait disturbance, irritability. In case of older children, they'll have poor scholastic performance and seizures. Chronic hydrocephalus, because of its chronicity, there will be physiological adjustments. So there will be no increase in the ICP, or the signs will present very late. The skull will have a beaten copper cranium or a beaten silver appearance in the radiological imaging, and there will be atrophy or herniation of the brain adjacent to the enlarged ventricle. And the other variant is the normal pressure hydrocephalus, where the cerebral ventricles are pathologically enlarged with normal or high normal ICP. It is common in older adults, and common presentation is gait disturbances, urinary incontinence, and dementia. Treatment for hydrocephalus is medical treatment is usually by a diuretic therapy, and for emergency purposes, spinal taps, which is a temporary treatment. Permanent treatment could be as an emergency procedure, extracranial ventricular drainage, and for a permanent procedure, shunting procedures like ventriculoperitoneal shuntings. Anesthetic consideration: difficult airway in case of pediatric and due to a large head, difficult IV access because of dehydration, multiple previous surgeries, and they will be on diuretic therapy. increased risk of aspiration because of altered sensorium, and also increased propensity for vomiting. They can have a dyselectrolemia, and the concern is to maintain a normothermia, to maintain blood pressure and cerebral perfusion pressure. And we have to take measures to decrease ICP, to avoid hypoxia, hypercarbia, and acidosis, and there will be a risk of venous air embolism. In case of pre-existing extracranial ventricular drain, there is a risk of dislodgement of during transfer, a risk of rapid CSF drainage. We have to avoid changing the height of the drainage bag during transfer with respect to the head. Pre-anesthetic assessment, we have to ask for the age and weight of the baby. Symptoms, as we seen in the clinical features, raised ICP, fever, or any focus of active infection. History regarding previous surgery and history previous anesthetic management, any adverse events. Birth history, any postnatal problems, developmental history because of poor delayed developmental milestones, immunization history, any allergic history, and drug history on current management like diuretic therapy, chronic steroid therapy, or anticonvulsant therapy, and regarding fasting status. On examination, we have to assess the general conscious of the baby, whether active or drowsy. Head to toe examination, we have to look for the fontanelle eye signs and signs of raised ICP. We have to measure the head circumference. An airway examination, which includes the Cooper scale for the pediatrics. We have to look for any difficulty in maintaining the airway, mouth opening, previous history of difficult airway, and range of neck movements. Systemic examination, which includes a complete neurological examination, including the cranial nerve examination. In the respiratory system, we have to look for any other congenital abnormalities like kyphoscoliosis, and is there any feature of respiratory tract infection. In CVS, abnormal heart sounds and murmurs to look for any congenital heart disease. We have to look for volume status and IV access priorly in the preoperative assessment, and we have to secure it in order to correct dehydration and dyselectrolemia, or in case of any emergency. Investigations are complete blood count, renal function test and serum electrolytes, blood glucose, chest X-ray, ECG echo, X-ray skull, and CT head. Pre-op optimization, we have to get the informed consent from the parent or the patient. NPO orders, and we have to correct dehydration and dyselectrolemia. Prophylactic anticonvulsant therapy, preferably 15 milligram per kg IV as a loading dose. To continue steroids if the patient is on chronic steroid therapy. Particularly, we have to avoid pre-op sedative premedication, which can mask the neurological status. Our patient may go into drowsy and hypoventilation, which further increases the ICP, and there could be increased risk of aspiration. While transferring, we have to clamp the EVD prior to transport, but not more than 15 minutes. Height of the bag with respect to the head should be maintained. Intra-op management, presetting the optimal OT temperature, adequate pads and bolters should be ready for airway management. Difficult airway cards should be ready. Monitors include pulse oximetry, non-invasive blood pressure monitoring, ECG, temperature, precordial step, EtCO2 monitoring, and urine output. In case of any hemodynamic instability, central venous pressure monitoring and invasive arterial BP is secured. Induction after adequate pre-oxygenation, IV induction is preferred, especially if the patient is stuporous and with signs of raised ICP. Preferable agent is thiopentone 3 to 5 milligram per kg IV or propofol 2 mg per kg IV. We should avoid ketamine. Inhalation is also an alternative induction agent in case of no IV line. Inhalation with sevoflurane, then followed by fentanyl 2 mics per kg IV or remifentanil 0.5 to 1 mics per kg. Muscle relaxation can be achieved with succinylcholine 1 to 1.5 mg per kg IV. In infants, or if there is availability of rocuronium 1 to 1.2 mg per kg IV is preferred. Then airway is secured flexometallic tube. Anesthesia is maintained with controlled ventilation, iso or sevoflurane with air and oxygen. We have to avoid nitrous, which increases ICP and also will lead to, it has a side effect of post-op nausea, vomiting. MAC should be maintained less than 1. We have to avoid PEEP or PEEP less than 10 millimeters of mercury. We have to maintain normocapnia and normothermia, maybe mild hypothermia, but not less than 35 degrees Celsius. IV fluids should be slightly hyperosmolar to prevent cerebral edema. We have to avoid dextrose containing fluids. We have to avoid hypotension, maintain mean arterial pressure and cerebral perfusion pressure. During positioning, we have to avoid neck twisting and turning, which decreases the venous return and causes increase in ICP. Mannitol can be used before craniotomy. During cannulation of ventricle, there is a chance of drop in the BP because of drop in the ICP. We have to provide adequate analgesia and relaxation to avoid response during incision, tunneling for VP shunting and laparotomy incisions. We have to provide intermittent opioid boluses and local infiltration with bupivacaine 0.25%, 0.5 ml per kg. Extubation, prophylactic antiemetic ondansetron 0.15 mg per kg IV should be given 30 to 60 minutes before extubation. Neuromuscular blockade should be completely reversed. And once the patient is completely awake and after performing all the neurological examination, examining the pupil size, smooth extubation should be performed in order to prevent raised ICP. Post-op management, patient is nursed in flat position, avoid head-up position to prevent over drainage from the shunting or drain. Standard monitoring, continuous vitals monitoring. Analgesia can be provided by combining with the local infiltration, paracetamol 15 mg per kg IV or per rectal. NSAIDs can be given if not contraindicated. We should avoid high doses of opioids, but low doses of opioids can be given, fentanyl or remifentanil. Frequent neurological examination should be performed postoperatively. We have to provide DVT prophylaxis in focal neurological deficit. Watch for adequate shunt functioning. Thank you, sir.
Very good. Have you ever seen a case of VP shunt being done
Yes, sir.
during your training?
Yes, sir. For adult
But
patient,
adult patient.
post-traumatic brain injuries.
Is it done under GA or local?
The patient was already intubated and with poor GCS, so we did it under intubation.
Intubation. So if the patient is not intubated and it is a patient with hydrocephalus requiring a VP shunt, what is the type of anesthesia the neurosurgeons prefer? Adult patient, not a child.
We can do it under sedation.
It can be managed by local infiltration anesthesia itself, because
Yes, sir.
as you said, it is not a craniotomy. It is only a bug hole which is made to approach the ventricle. To tap the ventricle, what you need is only a bug hole, not an open craniotomy. Similarly, to insert the catheter into the peritoneal cavity, you require just a small incision, not a laparotomy to insert the cannula. So both
Yes.
are very small incision, which can be managed with local infiltration with bupivacaine or xylitol and renal. Okay, so adults we can manage under local infiltration. It is only the pediatric patients, especially infants below 1 year of age, with a huge hydrocephalus. Most of them will not have any problem of ICP. That's why, if they are less than 1 year old,
Yes, sir.
ICP will not be a major problem. Even if they have a enlarged head and a large collection of
Sutures will not be fused and they'll be having bulging, more compliance.
Excellent. So the sutures line will give way and expand, and that will not reflect inside the intracranial compartment. So ICP will not be a common feature in children less than 18 months of age until all the fontanelles fuse. Okay.
Yes,
So it is only the older children who develop or continue to have the hydrocephalus without treatment who can show features of raised ICP. Otherwise, it is not a problem. Here, they keep the give you a case scenario with a small child of say less than 1 year, 9 months old child with a large hydrocephalus coming for VP shunt procedure. Then the examiners expect you to talk more in detail about how will you manage. So what is the position you will try to keep the child when you want to intubate the trachea with a flexometallic tube as you said?
Raise the trunk with the help of a flat pillow up to the level of the head, sir, and sustain the head
The
with
level
the
of
help of the head ring.
extramedullary meatus should be at the level of sternum, so we have to keep the bolster to raise the
It can be something like a ramp position that you do for your obese patients, or it can be a management with raising the body. As you said, thorax and abdomen portions are raised with either folded towels or a small pillow, and head occiput is made to rest on the table. In that case, I will show you pictures in the slide which will give you a good idea. And sometimes it may be intubation may be done in lateral position also. If the patient turn to one side, you can get a better extension of the neck, and you can do the intubation in lateral position also. So these are the two things that you have to be aware of when you answer the question, especially in Viva. If they keep if you get a case of hydrocephalus, this is the question that they may ask you, and the supposing the what are the post-op problems if the drainage is too fast of the CSF into the peritoneal cavity, what will happen?
There will be subarachnoid and subdural hemorrhage because of collapse of veins and
there may be volume depletion. Sudden intravascular volume depletion also can happen, and cerebral perfusion also can get affected. Okay, so that is another problem that we have to keep in mind.